It's really good to see that this conference is truly multidisciplinary, seeing a gynecologist and a cardiac surgeon and myself as a vascular surgeon in this session. It's very good to see this. So as Alex said, let me check if it works, the big green arrow next. We have to, yeah. So these are my disclosures. As I said, I'm trying to lead the perfusion work we do in Leiden, which is quite extensive, as you can see. We started, I think, in 2018 with our perfusion projects, and we started in the usual suspects such as colorectal, upper GI, and reconstructive. And we did an RCT in colorectal. We are doing an RCT in reconstructive surgery in deep flaps, randomizing between ICG and non-ICG. Upper GI, and we started a few years ago also in vascular surgery, revascularizations, amputations, and diabetic foot ulcers. And we're planning to start with HPB transplantation and also CABG. So Dr. Bratzi, I'd like to have a chat with you after this session to help us starting this up. So I just took a random example from the internet. I hope I don't know if it's from someone in the hall today, but this is a colon anastomosis, and as you see, it's beautifully green. But the problem, in my opinion, is this green enough, or is it too green, or what will happen with the clinical outcome of this patient? Of course, at some moment, fluorescence will be in the surgical field, but it's very important to know, how green is green enough. So what we did in the past in Leiden, we infused the ICG, and we did the fluorescence imaging, and we looked at the screen. And the more experienced surgeons said then, okay, let's give it the benefit of the doubt, or these intestines are looking quite all right. This flap will make it definitely based on the fluorescence. But it was all based on qualitative analyses. And as Dr. Rosenthal stressed during the advisory board meeting, how green is green enough? And does it get green? And how fast will it become green? How green will it be? Does it stay green, or does it get black again? And if you really want to answer these questions, you have to move from qualitative assessment to quantification, which is very necessary, in my opinion, to compare between patients and to compare between time points within patients. And when you want to do that, you need a time intensity curve, and it's not rocket science, not that difficult. The only thing you do is you plot the y-axis, you plot the intensity, and the x-axis, you plot time. So then you will get a time intensity curve, and what you can do with these time intensity curves, you can calculate certain parameters from these curves, as for the inflow, as for the outflow, time to max, for example, what is the maximum intensity, and you can use these parameters to predict clinical outcome and to guide you during surgery. And my talk today was about perfusion assessment, so I want to give you my insights of how to do a quantitative analysis of perfusion. Of course, you first have to inject the ICG and do the fluorescence imaging. Afterwards, you will need to select a region of interest. So, for example, in colon, this will be the anastomotic site, and in the gastric conduit, it will be the gastric conduit from the proximal to the distal side. And then you will have to do quantification, and I will get through these three methods that you can use for quantification. So first, these static methods. What you do in the static method, which is a bit old-fashioned, but you can still do it. You can get a frame, so of course it's a video, but you can get a random frame, for example, after a minute, and then you take two ROIs and you give one as a reference of the other. So you just calculate the number of photons on that image that you captured with the camera system, and you get one reference point, and you get the other point as a reference from the point that you think is good, well perfused. And mostly it's given as a percentage of the reference point. But the thing is, with a static quantification, is the reference point okay? Are you sure that point is well perfused? In my opinion, it's very hard to say. So that's a big problem of this technique. So then the absolute dynamic quantification. As a vascular surgeon, I will use some examples in the vascular surgery field, so don't be afraid it's not a colon or a gastric conduit. These are feet, and these, to show the example, are healthy feet. So this is from a person without peripheral artery disease, normal vessels, and we did a NRF fluorescence imaging, and we draw some ROIs, both on the left and the right foot, again, healthy feet. And this is what we saw. And this is absolute dynamic quantification. So what you're seeing is in two healthy feet, so all the parts of the feet should be well perfused. You see a big difference in the time intensity curves, and that's what happens if you use the absolute dynamic quantification. And if you use the absolute dynamic quantification, you use the maximum intensity of the signal as a reference. So this is what you're using, the maximum intensity. And because you're using the maximum intensity, it's dependent on a lot of parameters. For example, how close is the camera system to the field of interest? So if you put the camera system very close to the field of interest, it will become green, and it looks perfectly well perfused. But if you put the camera away, then it's different. So it's just the amount of photons that you'll catch by putting the camera system towards the tissue. So that and the dosage, the cardiac output, everything, the temperature, maybe everything is dependent on this absolute intensity. And there are some limitations because a lot of things influence the signal. And in these feet, for example, if you look at the lateral side of the feet, it looks like it's differently perfused than the medial side of the foot. But these are well perfused, healthy feet, so it should be the same. And that's why we came up, and it's not very, very hard, but that's why we came up a few years ago with dynamic normalized quantification. And what you're doing, you're taking the maximum intensity, you say, okay, this is 100%, and you're starting to look at the shape of the curve more than the intensity or the number of photons that you're catching. So some parameters you cannot use anymore, but for example, the ingress of the slope, so the steepness of the slope, you can use by normalized quantification. And if we go back to the example of the patient with the healthy feet, normalizing the curves will show this, and the curves will be far more close to each other, and this is what you expect in two healthy feet. So another thing that's in our opinion is important, and this is a paper that we wrote very recently, is giving reference curves for vital, normal, well-perfused tissue in a lot of organs. So what we experienced by doing all these studies in different organ types is that the normal reference curves are different. So a colon is different from a gastric conduit, is different from a reconstruction flap, is different from normal skin at the feet. So that's why we took tissue that we are almost sure that was well perfused, and we did it in a lot of patients, and we took the mean curves and we plotted it and published it. So here you can see the differences between the curves that we researched. It's just on PubMed. Okay, then a few examples in my field: peripheral artery disease and diabetic foot. It's a depressing slide. So if you want to enjoy the beach today, just don't read and don't listen. But it's what's happening nowadays. It's like a pandemic in diabetic foot ulcers and peripheral artery disease, especially in the United States. Over 2 million people are living with limb loss in the United States, and this will be doubled in 2050. Worldwide, 1 million amputations are being performed every year. So that means, as we are here sitting here today, 1,000 amputations are being performed today. In the United States, 1.6 million new diabetic foot ulcer patients will present, and diabetes is rapidly growing. So in 2030, over 630 million cases of diabetes are worldwide. And to give you a reference, in the US, 185,000 major amputations are being performed every year, so that's over 500 a day. And to compare this with breast cancer patients, breast cancer is approximately 280,000. And the cost this brings is enormous. What we as vascular surgeons trying to do in diabetic foot ulcers, but also in peripheral artery disease, is to reconstruct the vessels, to revascularize the vessels to get more blood to the foot. We can do it open. This was a case of previous week in a common femoral artery revascularization, and we could do it by endovascular means, by PTA, or inflating a balloon at the location of the stenosis of the vessels, in this case in the upper leg. And what we did in these patients categories is using ICG as a technique of getting more information about the perfusion of these feet and predicting the clinical outcome. So we did this in over 200 patients. I'm not going to discuss this today. The normal dose that we use is 0.1 mg per kilogram. And in Leiden, we nowadays use this as standard of care to use this as quality control before and after revascularization. And in this way, we try to predict in an early stage if the wound will heal or if the complaints of these patients will be less. So a short few slides about a new study that we're doing, a new trial, and that's the inflow study. And that's administering ICG intra-arterially during the procedure. So what we mostly experience in diabetic foot ulcer is that these patients have multi-level disease. So they have below the knee and up and above the knee problems in their vessels. And as vascular surgeons, we just don't know when to stop. So if we recanalize a SFA, so a superficial femoral artery stenosis, is that okay? We don't know. So because we don't know, we treat these patients very aggressively. So we're going to treat the arteries below the knee. This is costly, time-consuming, and very risky. So we don't know when to stop. That's why we started this study, only in critical limb-threatening ischemia, Fontaines 3 and 4, and we try to correlate the fluorescence results with angiographic findings, duplex ultrasound, and expected clinical outcome. And as you can see in the dose, it's a very low dose, 0.01 mg per kilogram, because you're giving it intra-arterially during the procedure. So this is again what we're seeing in viable quantification of the feet. So this is a case, and the video should start. After administering, you see within a few seconds, you see the arterial vascularization of the foot. This was a 83-year-old male with breast pain, and as you can see, the pre- and post-interventional curves are different. And this was a patient, 73-year-old male with an ulcer lateral on the MTP5. This is a bit of a strange thing. We don't see this when we administer ICG intravenously, but as you can see, the area of the wound is it's fast. It's glowing green very fast, and it's washing out also very fast. And what this means, we don't know yet. This is a proof of concept study that we can do this, that we can quantify it, and then it's safe in 30 patients. And afterwards, we'll do a phase 2 study to predict clinical outcome and to guide us during these interventions. We hope to expand soon, and as this is a very multidisciplinary society, we hope to also include the vascular surgery logo in the website. We would be happy to, and we'll also be happy to organize a webinar in vascular surgery soon. So this is our team in Leiden with all our PhD students and our collaborative network, and thank you for your attention.